Okay, live now. I'm just going to start the webinar.
Yeah, perfect. Welcome all to this webinar on the macroscopy of head and neck specimens. These webinars have been sponsored by the British Association of Urological Pathologists, the British Association of Gynecological Pathologists, and the Journal of Clinical Pathology. This is a part of a series. So this is day 2 of the series. We've had 3 webinars yesterday, and today we've got the head and neck webinar followed by the one on gynecological specimens and then urological specimens later in the day. As most of you are aware that each of these webinars require a separate registration. These webinars the basis of these webinars was a series of papers in a symposium in the Journal of Clinical Pathology that was published in the March 2024 issue of the JCP. I'm very, very pleased to announce that JCP has very kindly made this entire symposium open access. So you will be able to read these papers without a subscription. The head and neck paper, the lead author of the head and neck paper was Dr. Adam Jones, who will be chairing the session today. Adam is my colleague. He's a consultant histopathologist at the University Hospital of Wales in Cardiff. He's a co-organizer of the head and neck EQA scheme and a co-author of the RC-PATH pathways for head and neck pathology. Over to you, Adam.
Thank you very much, Murali, and thank you for organising the 2-day webinar on macroscopy, which is a significant undertaking to do. So welcome everybody, and thank you for joining us on the head and neck session this morning. We have 4 presentations to provide today covering the different subsites of the head and neck. And the first presentation that we will have will be on the larynx and neck dissections. We've had a slight change in order. The second talk will be on oral cavity and oropharynx, which will be provided by myself. Then thyroid and salivary glands. And then finally, surgical margins and 3D mapping. And we will present the series of presentations initially, and then we will move on to the final 20 minutes or so for a panel discussion. If you have any queries or questions, we'd be grateful if you could put those in the Q&A section on Zoom. And for those of you who are viewing on YouTube, it'd be great if you could put those in the chat function. And then we will try to answer as many of those questions as we possibly can. So the first topic today that we're going to present, this will be by Brendan Conn, who's a consultant head and neck pathologist in Edinburgh. Brendan's going to present on laryngeal resections as well as covering neck dissections. And he's the lead author for the Royal College of Pathologists in the UK cancer dataset on laryngeal resections, and he's an experienced examiner. So I'm going to hand over to Brendan, and we will start the presentation.
In this section, I'm going to talk about specimens. I'm going to talk specifically about total. In this section, I'm going to talk about specimens from the larynx and neck. For the laryngeal specimens, I'm going to talk specifically about total laryngectomy for primary squamous cell carcinoma. Laryngectomy is reserved as a surgical option for patients with advanced disease, and it's been shown to be the most effective treatment modality for patients who are able to undergo the procedure compared to other treatment modalities. Our role in the process is to sample these specimens to make sure that all core relevant dataset items appear in the report, that we are able to accurately stage the disease and are able to accurately report the margins to report back to our MDT. The content of the report is set out in the Royal College of Pathologists dataset, which is based on the ICCR International dataset. Laryngectomy specimens have complicated anatomy, which can be quite intimidating to the uninitiated. It is best to think of these specimens as a simple tube within which there are three compartments. The glottis deals with the vocal cords, the supraglottis is anything to do above the vocal cords, and the subglottis is anything going on beneath the vocal cords. And the structures are much more clearly seen in this Royal College of Pathologists Australia trimming manual picture, in which case the larynx has been opened from the back to reveal the tumour in the supraglottis, and we can see the glottis, we can see the subglottis, and we can see all the levels. Knowledge of these structures, the pre-epiglottic space, the thyroid cartilage, the cricoid cartilage, the paraglottic space and the extralaryngeal tissues is essential to be able to stage these tumours for the various subsites of the larynx. Vocal cord mobility is also given as a criteria, but I don't think this can really be reliably commented on in pathology specimens. This superior sagittal slice through the epiglottis and tongue base margin shows the pre-epiglottic space marked in red. This site through the level of the glottis shows the thyroid cartilages being invaded with through and through invasion on the left. And this section through the subglottis reveals cricoid cartilage and tumour extending anteriorly beyond the larynx into the extralaryngeal tumour, including the strap muscle. This and the previous two pictures are available with annotations in the Royal College of Pathologists dataset. On the receipt of a laryngectomy specimen, once we are sure it's been adequately fixed, we should go and process the neck dissections first. If there's an attached neck dissection, then I typically do a more detailed description of the larynx. I'll ink the right and left side, which I'll explain later. This is a good time to sample soft tissue margins. You can also consider sampling a block of tumour if you want to do ancillary studies, or if you feel they'll be necessary, PDL1 and things like that, and then it can go for decalcification. Here's a specimen. It's a total laryngectomy received on corkboard with a right and left neck dissection. The specimen is orientated as if the patient is facing us. The superior aspect is identified by the epiglottis. The first step is to remove and process the neck dissections, and then we are left with a larynx. And looking at from the posterior aspect of the specimen, I like to dictate all of the labelled structures if present. It may seem superfluous, but I find it's a good way of getting into the job and thinking about the process at hand. And then we go ahead and ink the specimen. The specimen has been inked right, blue, green, left, and red where the neck dissections have been removed. So when we see red on our slides, we know that this is not a genuine radial margin. Inking is very important, not only for the margins for the microscopy elements, but also while you're trimming. It can be possible to get distracted sometimes in the trimming room. Maybe a slice can get flipped over, and if it's not being inked, it can be difficult to tell which is in fact the right side and which is the left side, especially when it's symmetrical tumour anteriorly. So yeah, always ink, and I prefer to ink before it goes into decalcification. Here is another example of a laryngectomy specimen submitted with a bilateral neck dissection, which is more extensive this time, but the principles are the same. First we remove the neck dissections, then we get a look at the back and we see that this is actually a supraglottis / piriform fossa excision. Interestingly, we've had some distortion. It's been tied too tightly onto the corkboard and the piriform fossa has been squashed flat. Regardless, after inking, we can go ahead and take some mucosal margins once inked off the right lateral piriform fossa, the superior margin and the inferior pharyngeal margin. This was a very complex resection specimen of a total laryngopharyngectomy with an extensive pharyngeal tumour showing extension to the base of tongue and soft palate, and the specimen was received on its side. Indeed, it was noted in the surgeon's notes that even though the tumour did not cross the midline and went very high up to the level of the soft palate, it wasn't necessarily an indication to abandon surgery, but this is as large and as high as a laryngopharyngectomy as you'll get, and it's very complex. The following anatomical structures are labelled to get our orientation, and once the identification of the structures and inking is complete, we can go ahead and take some soft tissue margins radially around the soft tissue before it goes into decalcification. I think this allows us to report the margins more accurately and also protects the tissue from the effects of decalcification in case we need to do further ancillary studies. And now we return back to our original case. On the left is the posterior aspect, on the right is the anterior aspect. The first cut in yellow is at the level of just below the hyoid bone, after which we do a sagittal section through the epiglottis to get the superior soft tissue margin and the pre-epiglottic space. Then even slices are made horizontally through the whole larynx from its superior to inferior using the PM40. The one in the middle has been highlighted green. That is the area of the anterior commissure which can be the most calcified of all the slices and is the most difficult to cut. It may necessitate putting it back to decalcification if you can't get your cut through there. And once you've made all your cuts, you lay them out. And now we have the resultant slices all laid out in sequence on a nice clean board, and we've taken a photograph, and then we can identify the slices. We number the slices from top to bottom, 1 to 12, and look at the structures and decide which level is which. In this case, we made the decision that slices 1 to 3 represented the supraglottis, Slices 4 to 6 represented the region of the glottis, and slices 7 to 12 represented the subglottis. And we can tell already just by looking at these slides that this is an extensive transglottic tumour and there's infiltration of the cartilage. We just need to decide how are we going to sample it for the best optimal staging and for margin interpretation. So what do we sample here? Well, do we take option A where we put the whole thing in 12 megablocks? You can never be too sure. Option B, which is a far more conservative approach, taking just one small block but showing full thickness cartilage invasion. It's going to be a T4A, can't be any more than or less. Or is it option C, where we take a more careful logical approach? The answer is C. So the trainee and I discussed which were the best slices to sample here, and we considered slices 1, slice 4, 5, 6, and one from the subglottis targeting the thyroid. Slice 1 is our sagittal section through the superior aspect of the specimen. From that slice we see the epiglottis, the hyoid bone, and the pre-epiglottic space, with tumour entering the pre-epiglottic space. For our margin, this is our standard block we take for every laryngectomy or laryngopharyngectomy. Slice 4, which is the supraglottis, showed tumour at the anterior and left, and some infiltration of the left thyroid cartilage. This was sampled in 4 blocks, dictated as posterior left, anterior right, and posterior right. You can do this in a mega block as well if you wish. I'll talk about the rationale for a mixed small block and mega block in a minute. Slice 5 was in the region of the glottis and was the epicenter of the tumour, showing it in its greatest extent, plus also tumour going through the anterior commissure into the muscle. This was taken in a whole mega block. And slice 6, immediately below, we were interested in this margin here for our lateral peripheral margin. So this was sampled in 4 all blocks, again dictated posterior left, anterior right, and posterior right. So the rationale in taking a mixed small block and mega block approach to this case was we were interested in particular margins. The turnaround time for mega blocks in our department is considerably slower compared to small blocks, so we wanted to get the case going and be able to assess that margin, and also if we needed to take further deep sections for a full face, it would be far simpler to do that on the small block rather than having to wait for the mega block. That said, if you're doing it, then please do approach the slides as they come through, because there's nothing worse than leaving a slide to sit for a mega block to appear for a week and nothing's been done, and then you just have to take extra levels anyway. So always keep the path moving. Mega blocks are ideally suited for laryngectomy specimens. The microscopic interpretation is quick and easy, so you can report them faster than with a jigsaw puzzle approach. They're also quicker at the trimming bench because you don't have to trim them down, and they can accommodate thicker slices. I was saying earlier that laryngectomies are difficult to slice thin for various reasons, so a mega block is sometimes the best option. You have to remember that they are resource heavy, the turnaround times are long. Getting a full face section is technically difficult, especially with a complex organ like the larynx. So there are a number of disadvantages to mega blocks, but turnaround time is the main one. And now our last slice is a single section of normal appearing thyroid. For the thyroids and larynxes, we just maybe just take one section, or if you see lesions, sample them, and consider sampling it prior to decalcification as well, because if you want to do immunohistochemistry for a papillary carcinoma, for example, you might not be able to once it's been decalcified. The inferior and tracheal margin is usually not a concern in laryngectomy, and the clearance is usually greater than 10 millimeters. Most tumours are glottic or supraglottic. Purely subglottic tumours are very rare. It's typically a single shave section taken on fast, but you can supplement it with a cruciate slice if it's got a deep subglottic extension, if you want to measure it, but typically it's more than 10 millimeters. apart from when it isn't. This was an example of a patient who had field change. They started off with dysplasia, then developed carcinoma, and then they developed multifocal carcinoma all the way down the larynx. And this is a section of trachea with carcinoma within the lumen, a frank cut-through tumour, so this is a real problem. I'm going to move on and talk about neck dissections. Neck dissections are a mainstay in head and neck pathology. We'll get them for all sorts of reasons and included in all sorts of specimens. You can get them therapeutic neck dissection where known metastasis is removed. They can be done electively where the neck is clinically negative but metastasis remains a possibility. And we can get salvage neck dissections, which is surgical removal of recurrent neck disease where radiotherapy is no longer an option. And we get them with a range of procedures, and we can get them as a separate specimen on their own. For the purpose of head and neck pathology, the neck is divided into 6 recognised levels or lymph node groups, and each level is a group of nodes which are draining the site of the primary. The groups are determined by anatomy. The table lists the anatomical structures which determines each level. These are directly visualised by the surgeon that knows these landmarks, and we are obliged to take their opinion. But we can simplify it, where level 1 is the submandibular group, level 2 is the upper cervical chain, level 3 middle, level 4 lower cervical chain above the clavicle, level 5 is posterior, level 6 is anterior. Neck dissections may be received on their own or as part of a primary resection. They may be unilateral or bilateral. They may be received in separate pots with one pot for each level. They should come with a request form, and the request form needs to state, and invariably doesn't, but it needs to state what the levels present are. It needs to say the location and size of the suspicious nodes, give the clinical end stage. Invariably they don't, but this information can be gathered if we look at radiology reports, or electronic patient record, or the head and neck MDM minutes. So if the information is not on the form, that's not an excuse for not knowing it. We can ask the surgeon, or if you're a trainee you can ask the duty consultant you're on with, or you can just find out for yourself by looking up the various means. And if you're a trainee having not done very many of these, you can make a start, dictate the form, get the specimen out of the pot, dry off the specimen, call the consultant, and while you're waiting for the consultant to finish his coffee or whatever, you can take some photographs, and so that's all done by the time the consultant gets to the trimming room. We'll look at a case of a neck dissection from a 61-year-old male with an oral SCC in his midline floor of mouth. He was clinically PT4A-N1 with a left mandibulectomy and treated with bilateral neck dissection. So the method for neck dissections, I always say find a method that works and stick to it, and this works for me. So I identify the submandibular gland first and all the other levels, and then I identify level 1, dissect that out. A single section of normal submandibular gland and palpate for larger nodes and dissect out the larger nodes. My rule of thumb, although I quite frequently break it, is any nodes bigger than 10 millimeters are serially slice and embed the whole node. If it's between 5 and 10 millimeters, bisect it through the hyaline and put it 1 node per cassette. And for nodes which are smaller than 5 millimeters, they go on whole in multiple nodes in 1 cassette. Larger masses, I like to see them sampled in more than 1 cassette, at least 2 to 3, because we're looking for extracapsular spread, which is the key for staging in TNM8. If you're struggling to find nodes, then I find bread slicing through the remaining fat of the level is useful. You just squash the fat up against the trimming table with finger pressure, and any little knots or grittiness, you sample that. Frequently you sample vessels and nerves, but more often than not you'll find these small lymph nodes. And just repeat it for each level and repeat for the other side. If and when we find a large metastatic deposit in our neck dissection, we measure it in its largest dimension, we look for the presence or absence of extracapsular spread, we look for invasion of adjacent structures, so for example the red arrow is pointing the tumour infiltrating muscle. We judge if is it one node or is it several matted nodes. We sort of look at the contour and make a decision at the trimming bench whether it's one or multiple nodes fused together. Sometimes you can consider inking a specimen edge. There's no margins as such in a neck dissection, but it can give an idea of the anatomical extent of the tumour. And for these larger deposits, you should always sample in a number of blocks, because you may not catch the absolute optimum feature for extracapsular spread in one block. It may need to be a decision you make over a few blocks. And this is a very nicely orientated neck dissection received on board with actually the levels drawn on. You can't really ask for much more than that. And there's orientating sutures marked with yellow as a long suture marking level 2 on the left side, and the red marker shows the short suture marking level 2 on the right. And the standard procedure described earlier was followed. This generated 43 blocks, which would be 43 slides, which is 5 small trays. So for this bilateral neck dissection, that's a lot of material to be looking at. This was a very adequately sampled neck. And this was a very well sampled neck with 53 lymph nodes showing 3 positive metastases, and the site of the positive nodes are marked on the diagram. The oncologists really love this in the MDT because it allows them to plan their radiotherapy fields. Certainly was an adequately sampled neck dissection, perhaps oversampled, it's controversial. And the right neck also showed a good number of nodes, 63, with 1 positive in level 2, again marked on the picture. I don't really find as many nodes as this. My trainees are much better at finding a larger number of nodes than me, but usually if I find between maybe 25 and 40 nodes, I'll be happy. Now, an example of a unilateral neck dissection in continuity with a primary resection, in this case a partial glossectomy. So I separate the neck dissection from the primary to concentrate on the neck dissection first. There is some risks here. If you put your cut too high, then you risk the margins in the primary resection, and there's also the possibility of cutting through level 1 nodes. So I usually try to aim for the submandibular gland, as that tends not to be involved, taking care not to cut through any involved nodes which may be in level 1. And there was a degree of ambiguity. This didn't have lines drawn on it or anything, so we had to decide what the levels were with the information we had to hand. So most of them were on the corkboard, which made it fairly easy. The main distinction was between level 2A and level 2B. We don't have the spinal accessory nerve to guide us, so we just have to make a call. I think for this case I maybe met in 2A, which might have helped us decide where to put the line. And indeed, there were metastasis in levels 1 and 2, and they were all in level 2A. Again, a good number of nodes, with the positive nodes shown on the template for the MDT. 74 nodes for unilateral neck dissection. Again, that's very impressive, and I'm not boasting, this wasn't me, I just had a very good trainee on with me that day. We saw this specimen earlier in the larynx presentation, where we've got most of the levels but not all the levels that we need. Again, you can work around what you already know to use intuition to fill in the blanks. We saw this laryngectomy and bilateral neck dissection earlier, and this had no orientation whatsoever. Educated guesswork, or intuition, whatever you want to call it, but again we're guided by the information that there was likely to be a positive node in right level 2, which you can see. So that decided the division between level 2, 3 and 4. So again, you can work around these things using the information you already know. And that brings us to the end of this very quick journey through laryngectomy and neck dissection specimens. Essentially, if your macro is not optimum, then your microscopy report is not going to be any good either. Microscopy determines the stage, the type and the extent of therapy, and determines the radiotherapy fields. And the clinical context is key, so you have to know the extent and the location of the tumour, and you can find this information out. If it's not on the request forms, you can find them out from elsewhere. Optimally fixed specimens are the best, much easier to find lymph nodes, much easier to slice larynxes. Keep your descriptions down, think about your typist, think about the length of the report. Pictures are essential for before the cut up, while you're cutting up, and when you're reporting, and keep your block key logical, methodical and accurate, and it's useful if you can record it on MacroPath as well, especially if there's a failure in the typing system. Just some miscellaneous points that haven't been covered elsewhere. For laryngectomies, I don't open these from the back prior to trimming. It gives great access to the inside of the larynx, and you can see the structures involved directly, but I find it makes interpretation of the posterior aspect of the specimen difficult, and you get these awkward horseshoe-shaped slices which can be difficult to sample. I tend not to use the bandsaw before decalcification. Some places do, but I don't. Surgipath is the best, but it is harsh, so you have to be careful and have good, competent technicians following good protocols. I don't remove the hyoid or strap muscles before. Some guides recommend it, but I prefer to keep everything in place. Importantly, I prefer to say posterior specimen limit rather than the posterior margin. You'll find if you're calling the posterior margin, you'll get into heated discussions in MDTs with surgeons and have to discuss ear margins and things like that. I call everything else a margin, but for the posterior, I say posterior specimen limit. For the neck dissections, pins and needles are no good for fixing a specimen onto board. It'll just fall off into the formalin and you'll lose the orientation, so discourage your surgeons from doing this, as well as the risk of needle stick. I prefer pots for the separate levels, just find it so much more simple. The surgeon makes the call and you just follow the instruction. I don't routinely ink neck dissection specimens, but I will apply some ink with a extracapsular spread mass just to give an idea of the anatomical extent of the disease. Double counting lymph nodes is not ideal, but is sometimes unavoidable, especially if we're trying to go for every last lymph node, but it's something to be wary of. Thank you. Thank you for your attention.
Thank you, Brendan. So that was a recording that Brendan's provided on laryngeal and neck dissections. And the next topic will actually be on oral cavity and oropharynx, and that will be presented by myself. And it's an approach I use, which is relevant to those specific cases. And of course, like everything, in any case you deal with, you always need to adapt technique depending on the situation. So we'll just
In this section, I will talk about specimens from the oral cavity and oropharynx and provide an example of how these specimens can be approached. The principal treatment for carcinomas of the oral cavity is surgery with elective neck dissection for clinically node-negative disease, although small tumours may undergo sentinel lymph node biopsy.
Sorry, Marley, could you
A
share your
therapeutic
screen, please?
dissection is provided for those with neck-positive disease. Radiotherapy is generally used post-operatively and usually as a consequence of close surgical margins, bone invasion and lymph node metastases, whereas chemoradiotherapy tends to be more common in those with involved margins, which is usually considered less than 1 mm or in extranodal extension. It is therefore the basis of the pathology report, which is heavily reliant on macroscopic recognition and block selection, which determines the potential need for further treatment, be it surgical or In this section, I will talk about specimens from the oral cavity and oropharynx and provide an example of how these specimens can be approached. The principal treatment for carcinomas of the oral cavity is surgery with elective neck dissection for clinically node-negative disease, although small tumours may undergo sentinel lymph node biopsy, whereas a therapeutic neck dissection is provided for those with neck-positive disease. Radiotherapy is generally used postoperatively and usually as a consequence of close surgical margins, bone invasion and lymph node metastases, whereas chemoradiotherapy tends to be more common in those with involved margins, which is usually considered less than 1 millimeter or in extranodal extension. It is therefore the basis of the pathology report, which is heavily reliant on macroscopic recognition and block selection, which determines the potential need for further treatment, be it surgical or oncological. There are several national guidelines in managing cancer resections, and the information presented today is largely based on datasets published by the UK Royal College of Pathologists. I will include tumours from different subsites and an approach that I considered appropriate in those particular cases, but it is important to adapt your technique depending on the specimens received. It is important when managing head and neck resection specimens to understand normal anatomical structures, as depending on the site of tumour origin and subsites involved, this will impact on tumour staging. In addition, different areas of the oral cavity will have a different microscopic appearance, and recognition of this will influence how you interpret histology slides. In this example, we have a CT scan in the sagittal plane, and the normal anatomical structures include the anterior tongue, the posterior third of tongue. This is the vallecula going on to the epiglottis. The hyoid bone is here, with the geniohyoid muscle attached that extends anteriorly to insert into the mandible. The floor of mouth here, and then we come back onto the tongue. This muscle is the genioglossus muscle, which fans out into the muscle of the tongue. Highlighted in green is this enhancing tumour mass involving the tongue tip with extension onto the right lateral border. Clinical staging is heavily influenced by radiology, and this right image and the red arrow indicates the radiological assessment of tumour depth. This is the partial glossectomy of that case, and you'll appreciate the exophytic nature of this tumour with normal mucosa evident on the right side. From a dorsal view, the normal level of mucosa is approximately here and running along this area. And you'll see the tumour has a mushroom-like exophytic morphology. The way I tend to manage these specimens is to take coronal sections through the main tumour mass and then perpendicular slices for the anterior and posterior margins. In this case, transverse slices were appropriate, but in other specimens it may be sagittal slices be preferable. The cut sections are evident in blocks 1 to 8. Both blocks 1 to 8 represent the transverse perpendicular slices, with blocks 2 to 7 the coronal sections. On high power view, the normal level of the dorsal mucosal surface is here, and you can see the folding of the mucosa related to the exophytic tumour. On the ventral side, this is a little bit more subtle here. And this is the approximate level of the normal mucosal surface, with the macroscopic depth approximately here. This is in contrast to the perpendicular slice, which at first glance you will see the green line corresponds somewhat similar to the radiological interpretation of tumour depth, but this is essentially reflected in tumour thickness rather than depth. Very closely at this area here, you will see this fine groove indicating the true line of the normal mucosal surface, and this would correspond to the proximate tumour depth macroscopically. And of course, accurate staging of tumour depth is essential because this impacts directly on oral cavity tumours. This is in contrast to another resection specimen where you have more ulcerated tumours, where the normal mucosal surface may not be evident if you had taken a perpendicular slice through this section here, and therefore you need to consider trying to sample the adjacent normal level of mucosa to get a true accurate staging. This is an example of a resection for a buccal carcinoma. On first looking at the specimen, this may be difficult to orientate, but the curvature on the lower right side here represents the lower lip, with part of the upper lip here, and the commissure. This is the buccal mucosa, which extends into the sulcus both superiorly and inferiorly. When we look at the posteromedial tissue, this represents mucosa from the alveolar ridge and retromolar region, and superiorly this mucosa is from the tuberosity. This case was sectioned coronally with transverse slices through the posterior and anterior margins. There are a few areas of interest on this representative slice. The oral mucosa is on the right side with the buccinator here, and deep and lateral to this is the zygomaticus muscle. The carcinoma has infiltrated through the buccinator into adipose tissue. This area is of particular interest. This represents a blood vessel, and this pale grey to translucent material is suspicious for tumour. When you look at the adipose tissue, certainly at the inferior part of the specimen, the fat looks within reasonable normal appearance. However, in the centre you will see these thin fibrous bands dissecting through the fat and extending to the dermis. In addition, this also seems to be wrapping around the zygomaticus muscle. The histology section confirms the presence of a squamous cell carcinoma invading buccinator muscle and involving fat. The highlighted area in red shows the artery with perineural invasion, and this is at a distance and ahead of the advancing front, so this would correspond to a worse pattern of invasion type 5. The lower part of the image, the fat looks normal, but the central and upper part shows these fibrous bands dissecting through and extending towards the dermis. There are some small fragments of skeletal muscle here from the zygomaticus which are also involved. At higher power, what you would find is a polydifferentiated carcinoma that look distinctly different to the overlying oral cavity tumour. And cytokeratin 7 staining here, you'll see the oral carcinoma is negative. You have your lobules of minor salivary glands acting as internal controls, and this is a different tissue block to the H&E slide below, but you will see the extent of the adenocarcinoma in this tissue block. And what you have in this case is an oral squamous cell carcinoma with a coincidental metastatic adenocarcinoma from a distant site. So this case illustrates the importance of macroscopy, as appearances such as this, highlighted in pink, can be subtle and potentially missed if you don't examine specimens thoroughly. Bone invasion is an area of difficulty in head and neck tumours, especially differentiating between erosion and invasion. Clinically, this of course relies on radiology. And you will see on the blue circle here the normal fat attenuation on the left side with the normal alveolar process evident in the right image. Whereas on the green circle, you've highlighted the enhancing tissue mass, which represents your carcinoma. And on the right image, you will see the degree of sclerosis evident in the trabecular bone, this flattening of the alveolar surface. And this on imaging is suspicious for involvement of bone. So this individual underwent a low-level maxillectomy. You have your porcelain jacket bronded crown and the canine tooth present here. This is your tuberosity, your buccal sulcus and buccal fat pad. This is the palatal margin here. And the opposite side, this is your antral surface, which you'll see on the medial wall. This is cracked a little bit during surgical delivery. And your carcinoma is evident here. This was serially sliced in the coronal plane, and the gingival carcinoma is identified in blocks 3 to 7. Higher power view, once again the tumour is involving the buccal sulcus and extending onto the alveolar ridge, onto the palate. You will see the antral itself is normal, the bony margins are clear, the lateral margins also appear clear, as do the medial margins. The important section here is what's happening to the bone. You will see the cortical surface of the bone here, as well as here, compared to the more trabecular bone here. And there's flattening and blunting of the alveolar ridge. And this would be the area where you need to assess for potential invasion into bone. And as evident in the histology section here, what you will find, this tumour is just showing erosion and flattening with no infiltration into the trabecular and marrow here. So this would represent a T2 carcinoma, and you will see this quite clearly on the macroscopy here, that there's lack of convincing evidence of invasion. This is in contrast to a separate case. This happens to be a tumour at exactly the same site. What you will see here, you have an enhancing tumour with direct bone invasion, and on the buccal side you will see this bony sort of spicule just encasing that tumour. This is the matched section through the specimen. The carcinoma is here, and it is infiltrated through the alveolar process, but does not appear to have involved the floor of the antrum. And the corresponding histology section is here. You've got a bit of sclerosis in the palatal part of the alveolar process, whereas there's breach of the cortical surface and involvement of carcinoma into bone, making a T4 tumour, but the antrum is wafer thin but still intact. Another thing to consider in oral cavity tumours is the potential site of origin. Sometimes late stage sinonasal carcinomas may extend into the oral cavity, and in these situations you may have a history of non-healing socket. This individual underwent a hemimaxillectomy. The lateral incisor tooth is here, followed by the canine and premolars, with the second molar tooth. The pterygoid regions are here. This is the lateral wall of the antrum, and this is the nasal mucosa. When we look at the superior view, this is the lateral wall, this is the medial wall, the nasal mucosa is here, and the inferior conchae just here. So approach is quite similar. I just take coronal sections through this tissue. When you are looking at the pterygoid areas, coronal sections can be taken here, but sometimes actually transverse sections through the specimen can be helpful, especially when you're trying to determine whether it's just the posterior wall that's involved, which would upgrade a tumor to PT3, or whether the pterygoid plate itself is involved, which would stage it as PT4. In this case, you can see the extent of this sinonasal carcinoma. The medial wall of the antrum is involved. The lateral wall and nasal mucosa is involved too. There is breach of the medial wall into the nasal cavity evident in all three sections. One area to draw your attention to is the tumor here. This is sort of more pale grey compared to the rest of the more white cut surface evident here. And this was an area of sarcomatoid transformation within the carcinoma. Mandibular tumours are approached in a similar way, and this may be for excision of malignant tumours such as a mucosal carcinoma or an odontogenic tumour like an ameloblastoma. If you have the full thickness of the mandible, which includes the tooth-bearing region and lower border, this is termed a segmental resection, whereas a rim resection includes only the tooth-bearing region. The approach is similar in both malignant and benign tumours. However, in mucosal tumours, you would need to sample soft tissue as well, preferably before decalcifying the specimen. Two nerves are important in these resections. This includes the inferior alveolar nerve, which enters the mandibular canal on the medial surface of the ramus, and the mental nerve, which is usually in line with the second premolar tooth. Oropharyngeal tumours, especially HPV-associated carcinomas, may be managed by radiotherapy, chemoradiotherapy, or surgery. Unlike oral cavity tumours, where extrinsic muscles have no influence on tumour stage, in oropharyngeal tumours, extrinsic muscle involvement has direct influence on stage, and involvement would correlate to a PT4 tumour. Radiology is essential in determining the extent of tumour, and an appreciation of this will help in pathological staging and an approach to the macroscopic specimen. The left image reveals a tonsillar carcinoma highlighted in orange and a corresponding ipsilateral metastatic lymph node. Unlike CT scans, MRI provides excellent contrast resolution to assess extrinsic muscles of the tongue, and this area here represents the hyoglossus muscle, which is indicated in green. Just medial and posterior to this is the tumour involving the inferior pole of the tonsil, and there is no radiological evidence of muscle involvement in this example. Transoral robotic surgery has two potential roles. The first is the identification of carcinomas of unknown primary origin, for which the tonsil and base of tongue is a common site. In these situations, you may receive a bilateral tongue-based mucosectomy and tonsillectomies, and these should be serial sliced in 3 mm planes and embedded entirely. Another role for TORS is the surgical excision of carcinomas, and an example is provided here, which represents a tonsillar carcinoma. You can approach these cases similar to an oral cavity tumour with coronal slices, followed by sagittal slices through the anterior and posterior margins. Alternatively, you may wish to serial slice this in the coronal plane. The cut sections through the tonsil reveal this is almost entirely effaced by tumour. At the base of the specimen, which represents the closest margin, this is the superior constrictor muscle, which is a very thin muscle. The mucosal margin here is also close. If you look at the adjacent block, you will see the superior constrictor has been disrupted during pathological dissection, and therefore this should be considered a false deep margin with a true pathological margin here. When we look at the inferior pole of the tonsil, you will still identify the tumour, but there is no involvement at the extrinsic muscle at the base of the specimen. So in this situation, both the pathology and radiology findings correlate. Although at first glance the rest of the tissue appears within relatively normal range, you will see this separate pale grey nodule here, whereas the rest of the tissue does appear reasonably normal. This tissue block, highlighted in blue, should be viewed as suspicious for a separate, potentially synchronous tumour and needs to be sampled. The rest of the tissue does appear within normal range, and I do personally tend to submit the entire specimen in these cases. When we look at the corresponding histology sections, they correlate with the macroscopic findings. The image in red represents a cohesive HPV-associated carcinoma. The constrictor muscle is at the base of the specimen, and this is involved by tumour. The upper image, that pale grey nodule, does indeed represent a separate tumour focus. In summary, it is important to recognise the normal anatomical structures in a resection specimen, the need for a close working relationship with your surgical and radiology colleagues, and in addition recognise the different tumour subsites have different criteria for staging. I would also like to thank and acknowledge Mary Hart, my radiology colleague at the University Hospital of Wales, who provided the radiology figures for the talk.
So the next talk will be provided by Miranda Pring. Miranda is a senior lecturer at the University of Bristol. She's also the director of Head and Neck 5000, which I believe is one of the largest prospective clinical cohort trials of its kind. She's also a co-organizer for the External Quality Assurance Scheme in Head and Neck, and an author on the tissue pathways for the College of Pathologists in the UK. So Miranda will be talking about an approach to salivary glands. These are sort of the major glands rather than the minor glands, and on thyroid resections.
So for this part of the head and neck session, we're going to look specifically at macroscopy as it relates to thyroid and salivary gland specimens. The information presented is largely based on incorporating guidance outlined in the cancer datasets that are published by the UK-based Royal College of Pathologists. Now, these documents also include guidance on specimen handling and block selection. RCPath have developed the documentation with input from a range of UK-based stakeholders, but they've also respected the authority of internationally accepted guidance from other organisations including WHO, AJCC and ICCR. So we'll start with the thyroid gland and a quick recap on thyroid gland anatomy. If you can appreciate the anatomy of the gland, these specimens are usually quite easy to orientate, assuming there's no gross distortion secondary to the pathological process. So thyroid is an endocrine gland. It's located in the anterior part of the neck. It's usually described as having a butterfly shape with a left and right lobe connected by a central isthmus. And the isthmus can vary in size in different patients. In some it's very narrow, in other patients it's quite broad and well defined. In the patient, the gland would sit in the midline of the neck, crossing the trachea roughly in the region of the second and third tracheal rings, wrapping also around the cricoid cartilage. Surgically, it would be deep to sternohyoid and sternothyroid strap muscles, and in some resections you'll find that there's part of the strap muscles included at the anterior aspect. This is just respecting the fact that you may have extrathyroidal extension in malignant samples and ensuring that there's adequate surgical clearance. Now, if you imagine this thyroid is inside you in a patient, the patient would be facing us. This is the patient's right lobe. This is the patient's left lobe and the anterior surface of the gland. So this anterior surface is very bubbly in appearance. It's got a capsule on the surface. The right and left lobes of the gland are connected by the central isthmus. In a proportion of patients, around about 20 to 30%, you'll see an additional third lobe. It's called the pyramidal lobe, and you'll find it on the superior aspect in the midline of the gland, in the region of the isthmus. It's a normal anatomical variant. In some patients it's quite diminished in size as it is here, but in others it's quite prominent and elongate, and it can actually reach the level of the hyoid bone. It represents the embryological remnant of the thyroglossal ductus, so it's just a normal anatomical variant, but it can help you to orientate the specimen. I've just flipped the same thyroid specimen over, so we're now looking at the posterior aspect of the gland. If you imagine the patient is facing away from us, this is the patient's left lobe, this is the patient's right lobe, and this is the pyramidal lobe in the middle. You'll notice that the deep surface has a concavity, and this corresponds really to the imprint of the trachea with the thyroid gland sitting against it. Like other anatomical sites in the head and neck region, we do benefit from very close working relationships with our surgical and radiology colleagues. There's a lot of preoperative assessment and workup for thyroid patients, with a need to pass through a multidisciplinary team, sometimes on several occasions. So the surgeons can be very helpful in orientating specimens, particularly if the normal anatomy is significantly distorted by the pathological process. They can provide useful information on medication for the medical thyroid, so history of Graves, etc. And also information on intraoperative impression. So if the thyroid was stuck down and difficult to extract, this would raise a suspicion of extrathyroidal extension and a need to thoroughly sample the specimen. Our radiology colleagues will have often carried out preoperative imaging, so PET-CT and ultrasound assessment, and they can provide very useful triaging information to stratify patients according to the risk of malignancy. How do the radiologists stratify? A lot of UK-based radiologists will use British Thyroid Association guidelines and utilise U-staging methodology to risk stratify. Patients will receive a U grading based on the imaging assessment and ultrasound features. and the grades range from U1, which is essentially a normal examination, to U3, a nodule with indeterminate features, and U5, a frankly malignant process. Now, this grading system can also guide the need for assessment with fine needle aspiration cytology, and in parallel, the cytologists will use a similar grading system called a thigh classification to stratify patients based on cytological features. So the thigh grading ranges from thigh 1, which is non-diagnostic, to thigh 3, which has 2 categories A and F, where a neoplasm is possible, to thigh 5, which is a frankly malignant process. So most of our patients before going to surgery will have a summary of a U and a thigh grading, such as in this case U3 thigh 3F, which is an indication to proceed to a diagnostic lobectomy. So there are a range of potential specimens that can be received in laboratory, ranging from a total thyroidectomy to a lobe, an isthmectomy, or a subtotal thyroidectomy. There's an example on the left-hand side here of a lobectomy, and you can see there's a solitary nodule affecting the lobe there. The preoperative indication for that would be a U3 thigh 3F nodule. In contrast, on the right-hand side, we've got a frank malignancy, a pre-staged U5 thigh 5 nodule, and you can see that this is a total thyroidectomy, and the surgeon has orientated the specimen. The abnormality is on the left lobe there, which is grossly distorted in terms of its normal architecture, and you can see that there's a rupture of the capsule on the surface, which is an indication of potential malignancy. There are some basic principles that apply to management of thyroid gland specimens in general. One is that optimal fixation in an adequate volume of formalin is very important. Our local preference is to fix the samples for at least 48 hours. This helps to eliminate any architectural distortion and minimizes artifact with nuclear features when it comes to the microscopic assessment. Some people will slice the thyroid to speed up the fixation process. That's okay, but just be careful that you don't compromise the microscopic assessment further down the line. Photos are invaluable. They can help you to correlate with the preoperative imaging, but also the surgical impression, and of course are very useful for block selection recording. Measure the thyroid gland or each lobe and weigh it, especially if the sample is large. Always assess the front of the thyroid gland specimen to look for attached parathyroid glands or lymph nodes. If you do see any nodules, they should be sampled and processed. Examine the thyroid capsule to determine if it's intact, look for any defects, and describe the surface of the thyroid. Is it nodular, for example? Our local preference is to ink the anterior and posterior aspects of the thyroid in different colours, and in the case of a lobectomy, you may wish to ink the resection margin in a 3rd colour. You slice the thyroid, and if you come across any nodules, then you should also record the size of each nodule. Some nodules on slicing show a degree of calcification, particularly if the nodule is long-standing, in which case you may need to undertake a little bit of decalcification with formic acid. A transverse approach can be taken for most thyroidectomy specimens that are non-malignant. So you can section the right and left lobes and then take transverse sections, approximately 5 millimeters each. And then if you've got an appreciable isthmus, you can take sagittal sections through the isthmus as well. The encapsulated nodule, particularly those with a thickened capsule, should be treated as a potential follicular tumour, and as such thorough sampling is very important for these cases. Distinction between a follicular adenoma and a follicular carcinoma can be dependent on just identifying 1 or 2 small foci of full thickness capsular invasion plus minus vascular invasion. As a general rule, nodules less than 40 millimeters should be sampled in their entirety. Those greater than 40 millimeters, you should take at least 2 blocks per 1 centimeter. If you're going to be making a diagnosis of a thyroid tumour of uncertain malignant potential, which includes obviously F-TUMP and WD-TUMP, you need to go back to the specimen and make sure you've processed the entire thing before putting that out as a definitive report. Taking blocks for genetics and molecular profiling are also quite important these days, as there are a lot of genetic tests now available for our thyroid patients. Several potential cut-up methods for managing nodules, and particularly those that occupy most of our lobe, and the intention should be to ensure thorough sampling of the peripheral capsule. Serial transverse sectioning in the axial plane is probably the most commonly used technique, and these sections will also include the isthmic resection margin. You'll end up with some slices like these on the right hand side, and you should also pay attention to the characteristics of the nodule, whether it's well circumscribed, and variations in the thickness of the capsule. Alternative method is to identify the superior and the inferior poles and make a transverse cut across, above and below, and separate them off, and then you can then section the central portion transversely and take perpendicular sections through the polar fragments, and you can use a combination of regular and mega blocks as required. So that was a brief overview of the management of thyroid gland specimens. In the second part of the presentation, we're going to focus on salivary gland. Let's start this section with a little bit of background on salivary gland tumours. So if you recall, there are 3 major paired salivary glands: the parotids, the submandibular and the sublingual glands. But don't forget that we also have minor salivary glands scattered throughout the oral cavity, but also at other sites, including the larynx. And you can get tumours developing at any of these anatomical sites. There is a variation in terms of the risk of developing a tumour at each of these sites. The most common site to develop one is parotid, so 78% occur there, followed by submandibular gland at 12%, minor salivary glands at 10%, and the least common site is tumour developing in a sublingual gland at 0.3%. There's also a variation in risk of a tumour being benign versus malignant at each of the sites. If you get a tumour in your parotid, the majority, 85%, will be a benign diagnosis and only 15% malignant. The most common pathology in the parotid is a pleomorphic adenoma. Within the submandibular gland, 70% will be benign and 30% malignant. The highest risk site is the sublingual gland, where if you get a lesion in your sublingual gland, 86% will be malignant and only 14% benign. And the minor glands have a relatively even distribution, with just a slight excess of benign diagnosis at 55% versus malignant diagnosis at 45%. So take-home point here is if you get a sublingual gland excision, then the risk of it being a malignant diagnosis is extremely high relative to the other anatomical sites, and you should manage the lesion accordingly. This is a clinical photograph showing a typical presentation of a minor salivary gland tumour. It's presented here on the palate. Typically they present towards the area of the junction of the hard and soft palate. This one's well circumscribed. It's got a little bit of ulceration on the surface, which is secondary to trauma, but the diagnosis here is a pleomorphic adenoma. We're not going to discuss minor salivary gland tumours any further, because in terms of macroscopic management, you would follow the guidelines for oral cavity. In a similar fashion to the management of the thyroid gland specimens, there are basic principles that also apply to major gland tumours, whether they arise in the parotid, the submandibular or the sublingual glands. And again, to stress this very important relationship and partnership arrangement with the surgical team in particular, who may need to pre-orientate specimens for us before receipt in the lab. Particularly the parotid gland because the anatomy can be quite complex. Don't be afraid to call the surgeon up to the lab if they fail to orientate the specimen adequately. Fixation is important, a minimum of 24 hours depending on the size. Some people will increase to 48 hours. Basic standards, so measure, weigh, photograph the lesion, ink surgical margins as appropriate, and take a block key. In terms of block selection, at least 1 per 10 millimeters, and if possible, try and include a block that has normal salivary gland tissue in the background, adjacent to the tumour, and also the closest resection margin. Many people will block the entire tumour if it's smaller than 30 millimeters, and in the case of parotid gland tumours in particular, there may be adjacent attached periglandular tissue which contains small lymph nodes, so it's important that you examine the fatty tissue surrounding the parotid gland and sample any abnormalities or lymph nodes that you see. Some of the cancer resection specimens, so the malignant salivary gland tumours, will come with a fragment of resected nerve, and a typical example would be parotid gland and facial nerve. So it's important that the surgeon highlights the proximal and distal ends for you and that you sample as appropriate. And in line with the thyroid gland patients, molecular and genetic studies are increasingly important for these patients. So try and take additional blocks, obviously avoiding decalcification, and smaller blocks if possible rather than mega blocks. When carrying out your macroscopic assessment, it's important to be mindful about core dataset items that should be incorporated into your final microscopic histology report, and also clinical information that may be conveyed by the surgeon to the pathologist at the time of cut-up and transfer of the specimen. So important features that can impact on T-staging, on maximum tumour diameter, evidence of clinical or macroscopic extraparenchymal extension, which will result in upstaging of the tumour to T3, and broader involvement of skin, bones such as mandible or ear canal, or clinical evidence of facial nerve involvement, which would result in an immediate upgrade to a T4 stage. Most submandibular gland tumours will turn out to be benign, and the surgical resection specimens may also be submitted with a further reassurance of the results of a preoperative cytology sample, which in this case demonstrated that the tumour here at the edge of the gland was most likely to be a pleomorphic adenoma. So I would measure the gland in 3 dimensions, measure the largest size of the tumour. You can ink the edges of the gland and then bread slice. So this is the cut surface of the gland, and you can see the typical macroscopic features of a pleomorphic adenoma. It's well circumscribed, it's got evidence of encapsulation, it's got a slightly bossylated, bumpy surface, and this kind of white cream coloured cut surface appearance. Now these tumours can sometimes throw off small satellite nodules adjacent to the main tumour mass, so it's important that you do sample normal appearing tissue adjacent to the main tumour mass. So the parotid gland specimens do deserve a little bit more attention, because these are the samples that can be most complex, particularly if you're dealing with a malignant diagnosis. Parotid gland is located in the retromandibular fossa. It's bordered superiorly by the zygomatic arch. You've got the masseter at the anterior aspect, sternocleidomastoid posterior, and the facial nerve actually bisects the gland into 2 lobes, so the superficial lobe and the deep lobe. There's an excretory duct, Stenton's duct, which will project from the anterior aspect of the superficial lobe. There's a potential for variations in the type of parotid gland specimen that may be received. You can receive a partial resection or a lumpectomy, typically to manage a benign tumour such as a Warthin's tumour. Superficial parotidectomy involves removal of just the superficial lobe of the gland, and a typical example would be to manage pleomorphic adenoma. Total parotidectomy is often linked to a malignant diagnosis. You're removing both the superficial and the deep lobe and potentially sacrificing the facial nerve. And these specimens sometimes come with an extended resection that includes adjacent tissue. Examples would include skin, part of the zygomatic arch, part of the mandible, or inclusion of a neck dissection. So this is an example of a superficial parotidectomy. We've measured the sample in 3 dimensions, and then we've inked the different margins in different colours, and then just bread sliced the sample. And you can see the typical appearance of a pleomorphic adenoma. It's encapsulated and bossylated, and we've got this glistening white cut surface. Now, what we often find with superficial parotidectomies and pleomorphic adenomas is that the deep margin is very close. And this is because the surgeon aims to preserve the facial nerve that separates the deep lobe from the superficial aspect. So quite often we will have a close margin at the deep aspect, and this just needs to be communicated back to the surgical team. I'm just going to finish with an example of how to approach a complex parotidectomy specimen. This tumour is already T4. You can see it's extended from the parotid gland into the overlying adjacent skin. So it's all about confirming the histology and thorough sampling of the margins in this case. So in this case, the surgeon has pre-orientated the specimen for us, and we've inked the different resection margins in different colours. And then we've used a combination of mega blocks to examine in one plane of section, and the other areas of the periphery of the excision are examined essentially by clock facing, taking blocks at different angles so that you've sampled the entire periphery. This is one of our mega block sections, so you can see that we can see the tumour in its context with adjacent structures, but also multiple margins in the one section as highlighted by the different coloured inks. So this is clearly a T4 tumour, replacing much of the parotid gland but extending into adjacent fat and superiorly into the overlying skin. So just to summarise, thyroid and salivary gland specimens can be received in various shapes and sizes. There are basic guidelines to direct macroscopic management, but there's no one size fits all, so the approach may need to be adapted depending on the specimen received. Having a very close working relationship with other members of the MDT, particularly our surgical colleagues, is very important for optimising macroscopic management, but ultimately also ensuring a high quality microscopic report for individual patients.
Thank you, Miranda. The next topic will be presented by Dr. Margaret Brandwine, who's the Chief of Pathology at Mount Sinai West. She's also the Director of Head and Neck Pathology Fellowship and a past president of the North American Society of Head and Neck Pathology. Margaret has published extensively on head and neck pathology, many of which articles are used for guidelines on approaching cancer resections. In addition, has an upcoming illustrated guide in head and neck pathology that's soon to be published. So Margaret will present on surgical margins and the significance of the margins in the clinical context, and also the essential need for close working relationships and communication, clear communication with your clinical colleagues. Now, the role of 3D macroscopy might be helpful in providing that. So I will hand over for the Murray to play the recording.
Yeah, I think apologies, okay, for the IT glitches. Clearly, it's not time for me to give up my day job as a histopathologist, not just yet, anyway. I think Brendan would be playing the recording of Margaret's talk.
Thanks very much.
Hi, Brendan.
Is it okay?
Yeah, great. Yeah, Brendan, if you share your screen.
Okay. Share screen 2, share. Yeah.
Perfect.
Yes.
So let's go. Talk to you today about how we've shifted the very nature of margin mapping and communication of results using the paradigm of 3D specimen representation and 3D representation of the surgical defect. Turns out that we've been using this 5mm standard for about 4 decades. And the first official guidelines that we could find that recommended this standard was from the Royal College of Pathologists in London in 1998. So there was a lot of data from the 80s, 90s, the aughts, which support that patients with adequate margins have better outcomes than patients with inadequate margins. And these are studies which use this 5mm standard. And if you look at the bolded first set of numbers, this is with inadequate margins versus the bolded second set of numbers, which is adequate margins. So notice that features such as local regional recurrence rate. Notice the high local regional recurrence rate, the 55%, 30%, and it improves 17%, 18% with adequate margins. Look at the disease-free survival, which is rather low, 7, improves with adequate margins, 39%, and so on. But the story's a little more complicated than that, because there's certainly studies which demonstrate that using study in 2005. In terms of other features, here we have pattern of invasion. And if you look here, group 1 are patients with who have negative margins on frozen and negative margins on permanent section. And the number of patients with WPOI5 are very small percentage-wise. Then if you look at the opposite side, which is patients who have positive margins are frozen, positive permanent margins, the pattern of invasion for dispersed tumor pattern 5 is significantly increased. There's been of late a movement to look at, well, what is the optimal margin distance? And so this is the first study that I could find that basically addressed this question. This is a massive study out of China with over 800 patients
with oral squamous carcinoma. And so here they looked at margin status as a continuous variable. And patients were treated in a standard manner. They got post-op radiation for either PT4 or positive lymph nodes or inadequate margins. And concomitant chemo, cisplatin-based for extranodal spread or multiple positive lymph nodes. And what this group here is, they looked at the p-values for, and this line here, this is a hazard ratio. They looked at the p-values for different cut points for margin distance. They came to this conclusion that based on the lowest p-value, you have an optimal cut point of 7 millimeters or more. I'm not sure if this is actually the best. I don't think this is the best way to prove that conclusion. And certainly they didn't look at other variables, but this is the first large study that I could find that began to address this issue. There are a couple more recent studies. This one was out of Memorial and it was published in 2017. And this was for T1, T2 tongue cancers. And again, they looked at margin distance as a continuous variable. And they looked at here, this is time, this is cumulative local regional occurrence rate. And what they looked at here is at what margin distance do you have a change in outcome? So what this Kaplan-Meier curve here shows from 2.3 to 5 millimeters or more than 5 millimeters, there's no difference. When you look at this variable, so from 2.2 to 0.01, you have a significant drop here. And then of course, positive is a significant drop. So they came to the conclusion that at about 2.2, that's when you impact local regional occurrence. This curve here is a Cox adjusted multivariate analysis when you adjusted these features for tumor size and adjuvant therapy. And this distance cut point of 2.2 remained significant in terms of changing impact. Now, this was done by area under the curve analysis, and that really is how to pick the optimum cut point in a study, as opposed to the layout. And so what these authors said is they don't advocate for change in practice, and you can't if this is just a retrospective study, but for a more rational approach. And I read a more rational approach as is the need for prospective double-arm studies, which also look at multiple variables. Okay, this is another recent study. This is from Tosh et al., again in 2017, and they looked at 432 patients, all intraoral sites, all stages. There was no pathologist involved in the study. And again, they looked at margin as a continuous variable. And the conclusions were fairly similar to the Memorial study, where the local recurrence rate, so here is the local recurrence rate, up here. And this is the margin distance as a continuous variable. So when you go from 5 to 4 to 3 to 2, all of a sudden you start seeing an inflection point in the local recurrence rate when it comes to about 1 millimeter. So their conclusion was a close margin of 5 millimeters is a weak predictor, whereas a margin distance of about 1 millimeter is a significant predictor. So what do we do with this data? Again, this data comes from retrospective observational studies. So perhaps this is very similar to our conclusion in that margin distance obviously is not the only prognosticator, and there are other predictive features which strongly impact outcome. So again, this this issue really should be adequately addressed by prospective double-armed studies and including other variables that are known to impact outcome, such as pattern of invasion. So this was addressed in 2021 by a group from South America, COLA. And here, this was the first study to look at the impact of pattern of invasion and margin distance, looking at margins as a continuous variable. So they made a binary classification of non-aggressive pattern invasions, so 1, 2, 3, versus grouping together patterns 4 and 5. This was all intraoral tumors, but they excluded positive margins and then tumor sites adjacent to bone, gingiva, and palate. They had no discussion about how exactly the specimens, the margins were assessed intraoperatively. But what you see here are two Kaplan-Meier curves for the binary pattern of invasion. So the top one, you see non-aggressive pattern of invasion that's grouped together patterns 1, 2, and 3. And what they found is the optimal cut point, again, area under the curve analysis, the optimal cut point is a little under 2 millimeters. Whereas the area under the curve analysis for pattern 4, 5 grouped together was 7 millimeters. So I think that it's interesting data, and it shows us really where we need to go in terms of optimizing margin distance. Now I'd like to show you what we've developed, myself and Dr. Mark Erkin, who's a head and neck surgeon. And this is basically our baby of using 3D specimen representation.
Managing head and neck cancer depends on the successful surgical resection of tumors from a variety of locations. The success of cancer resection is therefore highly dependent on meaningful, accurate, reliable, and actionable information in real time. Despite the myriad advances that have taken place in head and neck oncologic surgery, the essential practice of margin analysis, communication, and documentation has remained in the Stone Ages. At the core of understanding this proposal is an appreciation of current practices, which are highly inefficient and fraught with potential pitfalls.
Let me break down the standard process of intraoperative cancer mapping. The surgeon resects a cancer specimen and labels it based on the anatomy. The specimen is brought to the frozen lab for analysis. Depending on the specimen complexity, the surgeon may need face-to-face discussion with the pathologist to ensure a common understanding. That means the surgeon has to break scrub, walk to the frozen section room while keeping a mental construct of how the specimen relates back to the surgical defect. The pathologist reviews the specimen and then sketches a crude drawing as a first step in cancer mapping.
The pathologist is completely blind as to what the patient defect looks like and where the specimen came from.
The pathologist proceeds to visually survey all the margin planes, making multiple scalpel cuts. Regions of concern are identified and slides are produced from those areas. The margin distances are read in millimeters. The pathologist's 2D map all the while becomes the only source of all of this recorded information.
At the end of this process, the specimen has been drastically altered and may not resemble its original three-dimensional appearance.
Now, here comes the hard part. When all the data is collected and the surgeon has scrubbed back into the OR, just how can I describe to the surgeon exactly where the close margins are located? It's a common problem because it's really rare for all the margin distances to be more than 5 millimeters at the first margin assessment. So the surgeon needs to break scrub again to come back into the frozen section lab. But now, what can he or she look at? The dissected specimen is basically unrecognizable for the surgeon. Again, the only common point of reference is that crudely drawn map. Then we go over the results, the surgeon scrubs back into the OR, keeping track of all the margin data, mentally mapping that data back onto the defect, and then goes and resects the supplemental margins that are necessary. Now, if the next round of margins doesn't clear the cancer because they may be positive, this process goes on and on and on.
This process is highly inefficient and disrupts surgical workflow. It prolongs anesthesia time for the patient, increasing the risk of complications. This process is fraught with communication gaps and creates an inherent point of error. If mispositive margins are discovered when final pathology is reported, it is too late to act. The patient's treatment and potentially their life depends on this vital step, the resection of their cancer. That crude hand-drawn map remains the only concrete documentation of this intricate process of margin mapping.
The desire for improved intraoperative image guidance for margin mapping is well documented in the literature. We're here to show you our disruptive, first-of-a-kind vision for enhanced intraoperative pathologist-surgeon communication. Here we use a 3D optical scanning device to generate a resection specimen representation prior to the dissection and histological examination. Using video conferencing from the lab into the OR, I show the surgeons exactly where they need to go back and harvest more tissue for cancer clearance. So rather than describing the margin status over the phone or having the surgeon unscrub and show him a crude drawing, I can now just orient the surgeon to the specimen and point to the regions of concern. We have the data, we have a prototype, and our devised workflow has been successfully integrated into the frozen section process. So I took this mucosal reflection here of margin, and that's positive.
Okay, margin work is on the legal aspect and the right in line.
Okay, so what we do is we use a 3D scanner in the frozen lab, and we scan the specimen prior to dissecting it. So this adds about a 15-minute upfront processing time. And then once the specimen has been scanned, the 3D model is put together. But all of this while, I have the specimens now in my hands, I'm inking it and mapping it out. And then once the slides are produced and I've read them, I then annotate back onto this 3D representation and show this into the OR as a video. And so here is the white paper that we first published in 2022. And here's the editorial that accompanies that. That's in 2023. Now I'd like to show you another example. And so all of this documentation also allows for clarity in terms of documenting where the margins of risk are and what's been done to address those margins at risk. And we call this our frozen section timeout. So just to recap what we talked about before, from the main specimen, we had a closed margin that mucosal and deep, and that was F2, and we discussed exactly where that is in the specimen. And then on this side, number 5, we had a closed margin that we discussed before, right? Now this part D, you sent before the specimen, so that addresses this 5, that's the floor of mouth margin. The supplemental buccal labial, which was sent separately, that was negative. So that addresses this margin. And where the wedge resection from the lip, where is that on these pictures, or it's not on these pictures?
No, I can't represent it there, but it actually represents the deep, the ultimate deep margin of that buccal labial, where I sent that supplement, which was negative. So that should represent the final margin here.
Right, so I'll have to take your word for that because I can't conceptualize that, but yes, that's negative.
Okay, all right, so
Okay, so here is the ultimate product of that. So this is a recent publication from Head and Neck Pathology. This is this year. So when we surveyed head and neck surgeons, pathologists, head and neck radiologists, and radiation oncologists, and we asked them, where is the information gap in a report? The radiation oncologists, their response was that the overall largest, most significant gap is what is the final margin status? That's no surprise, of course, because here you have all of the margins from the resection specimen. You have margins from the resection specimen. You have margins and results from the defect. Do they, in fact, match up? And so by using our reporting system, we in fact document that, yes, these margins do map up. And then we have a visualization in the report that I'll show you in just a moment, which shows where the margin, the region where the margins of at risk existed. And this will help the radiation oncologist to plan treatment fields and also boost these areas. So this is an example of what we call an enhanced surgical pathology report. These 4 pages here, that's the body of the report, that's the narrative, also the cap. And then after the report, we upload this visual documentation, and this is produced from screen captures of the specimen representation, the defect representation. So here we've mapped this to the margin, to the numbered margins. In fact, when I survey the specimen, I make cuts throughout all the surfaces, but I only annotate where margins are that I've taken to examine. And then here, the surgeon has annotated where the resection specimen, where the supplemental margins have been harvested. Here, in addition, the surgeon selects immediately post-op radiographs, which show exactly what the extent is of the resection specimen. All of this is basically tailored for the radiation oncologist in mind. And this is the final margin reconciliation table showing the margins which were at risk, meaning 5 millimeters, less than 5 millimeters, and the supplemental margins which were harvested in response to these margins at risk. Here's their results. And then we can issue a statement at the end of the report that says that we've agreed that all the margins at risk have been reconciled or not. Maybe we have an outstanding margin which could not be reconciled. Here's another example of that. And here we have 4 pages up top, which are just the blurred out resection, the report, the narrative, the cap. And here we have the resection specimen. This was a nasal specimen. And here I've annotated where I actually sampled the specimens. This asterisk here shows you where you have a margin at risk. This is a 3D representation from the surgical defect, and it's been outlined by the surgeon to show exactly where supplemental margins were harvested. And again, this is additional images that are inserted by the surgeon into the pathology report to show the radiation oncologist where there were margins of concern initially. And again, here is the margin reconciliation table. And again, in this case, all the margins have been reconciled, but still it's useful for the radiation oncologist to know what areas were there had been difficult to clear. And so those areas may get a boost. Okay, and with that, I thank you very much.
So that concludes the presentations for today. I apologize for some of the technical issues that we've had with some of the recordings. some of the reasons we've done recordings is despite all of us being head and neck pathologists, most of us have got some head and neck colds, shall we say. So so it might have been slightly more difficult to do some of those live. There's been some questions, and some of them are sort of overlapping with regard to the sort of point in all the topics. And we've got Dr. Selvan Thavaraj, who's going to join us as well on the panel, who's a consultant pathologist from Kuala Lumpur, and he's formerly senior lecturer and honorary consultant at King's College and Guy's Hospital in London. He's published both for the ICCR and College of Pathologists guidelines, and also for our UK multidisciplinary team guidelines too. So we'll just start with a few questions initially that was raised, and some of those were with regard to bone and how approaching bone. One of those was with regard to how we go about sectioning it, but then also what sort of we use for the actual decalcification process. That some of those, of course, are relevant to the larynx as well. So I guess from my basis, when I start, if we're looking at mucosal carcinomas in particular, then and you have a bony excision margin with that, my preference is to try to remove a significant amount of that soft tissue, so you don't have the effects of decalcification on those solutions. And some of the techniques for that, you can use something like a Howarth's retractor, which will help you sort of lift the mucoperiosteal layer. It's a technique that's commonly used by max fac surgeons and ENT surgeons and dentists for surgical practice. And you can use that in pathology to help elevate that. I also find that quite helpful with like rim resections where you may have questionable invasion. You'll find if the periosteum ridges off really easily and nicely, you can be fairly comfortable. There's unlikely to be bony involvement. But sometimes you get that sort of firmness, a sort of tethering on it, and then you sort of index of suspicion raises a little bit more there of possible involvement. And another part, the way I tend to sort of deal with those, and some of those I will sort of section them either with a handsaw or a bandsaw, again depending on the technique, but you do need to be very careful in if you've got some of the soft tissue, certainly before any element of decal. The bandsaw and saws can damage those tissues, so I've got to admit I personally use the scalpel to create those incisions almost, so I'm essentially just cutting the bone itself. I have a fair preference actually for a handsaw because it's the tactile sensation that I like, but I do use a bandsaw. So I was just going to open it up for Miranda, Selvan, and Brendan, just to see whether your approaches were different or similar.
Thanks, Adam, for that. That's very, very helpful. I think the first thing I'd like to say is that I don't tend to use a single rule for all the specimens. I'm always, I suppose always without exception, guided by the extent of both the resection and the tumor. I'm always guided by the radiological appearance as to the degree of suspicion of bone invasion, and therefore how much I might need in terms of completing my final report in terms of staging. So usually those cases where I'd like to separate out the soft tissue might be those ones where we have a nice, neat alveolectomy, say a maxillary or mandibular alveolectomy, with very little suspicion of bony invasion, one of those rim resections. Sometimes that might be helpful, but I always take with a bandsaw, a slice in the radial plane through the deepest part of the soft tissue extent of the tumor, so I can get the deepest margin of the tumor and its relation to bone all in one piece, preferably all in one block. So yes, where there is very little suspicion of bone invasion, it speeds up the reporting process. And like you, I like the the Howard's nasal respiratory, as it used to be called, or a Mitchell strimmer, just to get subperiosteally and just do a subperiosteal removal. And that's when sometimes, a short stint in a junior surgical rotation always comes in handy.
Definitely agree with that. Brendan, what about yourself with regard, I guess, from larynxes, essentially, which we'd need to approach?
From my perspective of the bandsaw, I'll just start off with that. Is I use an exact water-cooled bandsaw at the moment in my practice, which works excellently. But before we had that, we had just a standard like DIY bandsaw in our lab, which was nowhere near as good. And all we could really do with that was to cut, say, a mandible into smaller sections to ease the decal, and then once it had been decaled, then section through the slice nearest the cut, which is often the softest. This is after dissecting the soft tissue first, of course. But the water-cooled exact bandsaw that we use is really essential. Anything less is just is diminishing returns, really. Regards to larynx, what was your question, sorry?
It was just with regard to your sort of more of approach, essentially, which I think you've pretty much covered for all intents and purposes.
Yeah, that's right. Yeah, I tend to decal the thing whole. I'll return it if the anterior commissure is not completely decaled. That's always the last one to decal because it's often heavily calcified. And I found myself trying to go for it, thinking, well, I've got the specimen on the table now. I've got to do this now. I try and make the cut, and it's gone off to one side, or the blade slipped and things like that. So again, I've got a very low tolerance just to sending it back for another day in decal, just so you can get a nice slice off with that.
I just want to sort of echo your thoughts, Brendan, about the use of a water-cooled exact bandsaw. It's almost essential to head and neck pathology laboratories. We've always used that as well, and I think it's the exact water-cooled bandsaw is also quite useful when you want to incorporate soft tissue bits in your in your slices. I find it goes through soft tissue quite well as well as hard tissue, but it needs to be supported. So there's a bit of an art to supporting the soft tissue bits when you go through it. So in our previous experience, we would actually do transverse slices of the larynx in a bandsaw and then decalcify the slices. And when we do that, it takes no longer than 24 hours in 10% buffered formic acid.
Did you have the slices in separate pots in your institute? Yeah.
We do. So like yourself, we ink them, differential inking left and right, because once you don't know whether you might flip it. We take macro photography, and so we number all the slices, and then we put each slice in a separate pot.
I guess the other question that's been raised is, what solutions do you use for decalcify? I mean, my solutions I tend to be Goodings and Stewart's, which is that sort of formalin and formic acid, essentially. That's my general approach, but I know there are lots of different sort of approaches and techniques for that. What about yourselves?
We use SurgePath for our head and neck, and I think it's hydrochloric acid based. It's really good for getting your sections back quick, but it really does affect the quality of the staining. You can get a tooth within a couple of days. You can get a mandible within a couple of days, a maxilla in a day, a larynx in a couple of days. So as far as the turnaround times are concerned, it's great, but the quality of your H&E staining will be impaired. So it's important to take non-decal blocks for your ancillary studies and things like that.
Yeah, that's always the issue, isn't it? It's that efficiency for the report with regard to the quality of the soft tissue generally. And there's no perfect solution, and you say you just got to adapt techniques ultimately as necessary. I guess since we're on larynxes, etc., Mega Blocks has been raised. as one of the questions, and I guess they can be used in many different specimens. Just sort of what the sort of panel's view of approach to mega blocks. Do you use much at all? What about yourself, Miranda?
Yeah, I mean, I think I would use a kind of combined approach depending on the specimen, but certainly for larynx, most of my sections would be, transverse mega blocks through, with perhaps some separate small blocks for mucosal margins. And similarly with a maxilla or a mandible, depending on the size of the specimen, a combination of the two.
Yeah, I agree. Yourself and Brendan, are you similar?
So I trained in places which didn't have mega blocks, so everything was done via the sort of jigsaw puzzle approach. And I've trained in places which did have mega blocks, and I work in a place which does have mega blocks, and they're really helpful for the reasons I stated in my presentation. But they do take up a lot of they do take up a lot of resources. We had that paraffin shortage in the UK. So we were warned about using too many mega blocks for the paraffin for the blocks, and the turnaround time and the technical difficulty with cutting mega blocks with hard and soft tissue. And we've got to start thinking about our technical colleagues as well. So I try to use a maximum of 3 for a larynx, for example, but it varies.
Yeah, I mean, I trained in largely trainer centers that didn't have mega blocks, and so we were forced, if you like, or trained to think very carefully about block selection in large pieces, and almost had to justify why you would sample a bit of larynx, what information it was going to give you. I mean, it wasn't very nice during the reporting stage. It's much nicer to see the mega block, but my biomedical science colleagues, I wasn't very popular with them once I started to submit, especially if the larynx is not sufficiently decalcified. It's difficult to get a nice clean mega block slide.
I think that the lab staff can sometimes get upset as well if you go and request genetics afterwards, and then they have to section those mega blocks. So you get an interesting response from the lab after genetics request.
Or immunohistochemistry, if you haven't got an undecalcified normal size block, you're going to have to melt down the block and take a slice and re-embed it anyway. So
I guess that comes back ultimately when the sort of approaches to figuring out how much decal you've has processed the procedures happened. So things like chemical testing, etc. Can use. Got the physical sort of test. I got in the mandible. One of the things I do tend to do is I tend to take a slightly thicker block, a block which wouldn't be relevant. And it's often got a tooth in it, because my view is if I can get through that pretty nicely, the rest of it's perfectly fine. But that would complement the sort of more chemical testing approach for that. I'm sort of semi-conscious we are running out a bit of time, but just sort of very briefly, there's been a couple of questions on neck dissections and the sort of roles of sort of inking in neck dissection, and whether there's any need there. I was just wondering from your perspectives what your approach is with regard to that.
Adam, are you able to summarize what we said in the WhatsApp group chat?
All right. So there's some of the discussions with sort of neck dissections. So a few of the participants have asked about whether necks themselves should be inked at all, and the value in sort of doing that. Part of that, of course, is going to be related to things like extranodal extension, etc., and trying to determine whether margins are sort of relevant in neck dissections, be it the deep or these sort of superficial. I mean, for me personally, I do tend to ink just the deep margin, usually just on those where there's either clinical evidence for extranodal spread, or I'm already suspicious before I've started sort of blocking the neck dissection out.
I think I would generally do the same. I mean, if you've got a suspicion of extranodal extension, it looks close when you're examining the specimen, I would tend to ink it
generally the surgeons don't seem to be interested. Most of the lymph nodes are buried within the specimen. So I think it's on an independent basis which specimen you're looking at. But generally, I don't think, to be honest with you. Don't see the need.
No, it's not as if they can go back in and find the bit retrospectively. That's the, yeah.
That's great. I think we've probably covered nearly everything. Oh, there is a question that's come up about frozen sections on specimens. I must admit, our surgical colleagues don't tend to take too many frozen sections, actually. My NT colleagues would more likely to take them than maybe our MaxFax team would. But anybody like to comment sort of on that?
Well, our head neck surgeons work in a hospital which is 20 miles away. So we'll maybe only get a couple a year that's taken over by motorbike.
Yeah.
The secret is to keep the surgeons at a safe distance, is it?
Yep.
There's also actually a question, if I just go back to the extranodal extension, how many blocks should be taken? I know, Brendan, you covered that in your talk. I mean, for me, I do generally just take just a few blocks if there's, macroscopically obvious extranodal spread. And what about yourselves? Obviously, I know, Brendan, you do. Selvin, Miranda, you similar, or do you block the whole node out?
No, like yourself, Adam, it's keeping the staging in mind is all we need to do. So, you wonder what the added value is of, multiple blocks if you can already pronounce on external extension for the purpose of staging.
Yeah, I would agree.
I think we've covered essentially the majority of the questions, and we're conscious we run over time again. And I just like to thank everybody for presenting today, and for those of you joining, Murali for organising the 2-day webinar, and which I know concludes today with 2 more sessions to go.
Thanks,
Thank you
Adam.
very much.
It's been a pleasure, and it's been a pleasure listening to you guys. Different aspects that even people who do other subspecialties, the mega blocks issues that you bring up, I think is quite a serious one, because I think in many centers there is a significant abuse of mega blocks. I'm not saying that mega blocks should never be taken, but they're certainly excessively used. Thanks very much. A very interesting discussion. Thank you, everybody. So this afternoon, an hour from now, we'll be starting the gynae session. And then finally, later in the evening, we'll have the one on urological or GU pathology. See you all then. Goodbye.